Hey guys, Dr. Sil here. Welcome to another video. Today I have the absolute pleasure of speaking with Dr. Laurence Boss, an anaesthetist at St. George Hospital. Is it all right if I call you Lawrence?
Definitely.
Yeah, great. Lawrence and I are going to have a talk today, and we're going to talk a bit about his career, and I hope you guys enjoy. Also, before we start, I want to say a massive thank you to Colonel B, who donated today's coffee through the Buy Me a Coffee app. I'll put a link down below if you want to buy the episodes more coffees, but really appreciate that, Colonel B. Thanks. Lawrence, I guess a nice, good question to get started with is if you can give us a bit of a summary of your career.
It's interesting. It's a common interview question, as in when you're going for a job.
Do you do many of the interviews, by the way?
Well, I had one this morning.
Oh, right.
Yeah. And it wasn't asked. They didn't ask you to summarize your career, but it was definitely one that I had thought about. Mostly, though, I don't think people really want to know the ins and outs of what you did all the way through your journey, but the sort of maybe the highlights or what was dear to you.
Right.
The things that I sort of fondly remember across, I guess it's 20 years, is starting out as a house officer in the UK, in Brighton, and having a couple of mates around me, all as scared as I was. And I don't think you realise how scared you are when you start your job. What you realise is when you're handing over to the next person a year later, and you look at them and you think, you're really nervous about starting medicine. I must have been like that. And so you only generate the insight into, I think, how anxious or anxiety producing it was when you see what you were probably like, having journeyed through that year.
I found that too. Now I'm a resident. I'm a solid year into the career, ready for retirement, but no. And yeah, like working with interns for the first time. Like I had medical students as an intern, but it's not the same. Actually having a colleague who's an intern, seeing the difference and how far you've come in a year is pretty interesting. So you started in Brighton, right?
Yeah. The gay capital of the UK.
Oh, right.
Yeah.
Didn't know that.
And one of my first jobs was actually with a urology surgeon who did sex changes.
Oh, okay.
Yeah.
As an intern, that was one of your first
Yeah.
introductions to medicine.
Yeah, so I was helping to kind of manage those patients on the ward and afterwards. And then I think probably the next interesting kind of part of my life was as an anaesthetic registrar. Found myself flying around in a little 5-seater fixed wing to Europe, picking up people who had been on holiday, come a cropper maybe in a trauma moped accident, ended up in intensive care, and were being repatriated by the insurance companies.
Yes.
And so I would fly out, go in an ambulance to the hospital, then fly them back to wherever their hometown in the UK was. And although obviously, you know, a cohort of patients who had something terrible happen to them in their lives, it was sort of relatively rewarding to help bring them back to their loved ones, but also, you know, fascinating in terms of the transfer medicine.
You would have had a good exposure to a lot of the kind of technology that anaesthetists would use, right? Like you would be, are these medical planes, like medical transfer planes? Oh.
No, but fitted out, so kitted out.
Right, so you had like monitoring.
Yeah, the whole shebang.
Yeah. Did you ever have any mid-air emergencies where you had to intervene on things, or was it usually they were pretty stable before transfer?
Lots of protocols, lots of good non-technical skills, amazing nursing staff that go with you, and the pilots were all obviously very familiar with the processes. So lots of safety built into the process and the journeys. And you'd stop, you'd land, you'd have to stop off because you were carrying more weight on the way back than you were on the way there from the patient and a relative. So you'd stop off in somewhere like Lyon in France and refuel and just check everything was okay and then carry on. And these patients were stable. So rarely were they unstable enough they couldn't go in an ambulance or go in a plane. But it was hard to convince the Italian paramedics who would come and collect you from the airport that you didn't need to go blue light siren down the central reservation on the way to the hospital because there was no patient on board. So much to the calls of it's okay, you can just travel at the normal speed on a normal road, straight blue light all the way down the central reservation. which again you just had to accept when you went to these places. The norm is their norm.
Yeah, you do what the cops want. Yeah. Oh dear. And you don't drink coffee, so I bet you that wakes you up pretty well, though.
Yeah, that's right. Yeah, I just never have. Like, I don't know whether it's because I've never grown up.
Is it an English drink when you're?
Yeah, it's sort of
I know tea
gathering momentum. Yeah,
Yeah.
tea would be the sort of classic, but I don't do that either.
Right.
Just water or beer,
Right.
but never together.
All right. Quick side. What's your favorite beer?
Anything by Willie the Boatman in Sydney.
Oh yeah.
They're a nice little local brewery doing some amazing stuff. And then in Botany, there's a place called One Drop, and they do an eclectic mixture of beers. So it's pretty punchy. I think it's 8%, but their milk oat IPA.
Milk.
Yeah,
Right.
is fascinating.
Yeah. So you're doing this light aircraft transfer part of your career. How old are you there? Or what PGY are you?
Equivalent.
10? Are you 5 years out of uni at that point?
Yeah, probably mid registrar level. So maybe 5 or 6 years and 3 years into anaesthetic training.
Yeah, right.
And so that springboarded me on to getting an air ambulance job in Sydney. So I at the point at which I was in my final years of training, we decided that we wanted a year away, my wife and I. And we had 2 kids at this point. And I got jobs in Canada and in Sydney. And my wife said, what's the lowest temperature that either of these 2 countries get to?
Wise person. That's a good question.
And so that we ended up in Sydney.
Wow.
Yeah. And so then I worked at St George for 6 months. I went back.
So what was your relationship with St George at that time professionally? Was it a air ambulance?
Did 6 months of air ambulance,
and
it was twinned with a 6-month stint as a fellow here.
Oh, well, that's great.
Yeah.
So 6 months on ground, 6 months in the air.
Yeah.
That's a pretty good mix.
Yeah, it was lovely. It was great, and we travelled in every direction for 2 hours.
Is that still going on, by the way?
What?
This air ambulance contract?
No,
I would be interested in learning about that.
Yeah. No, but there's several colleagues who work in the department who still do a hybrid job.
I've seen them drop off, and well, I don't know if that's the exact
people.
position, but on the helicopter transfers, or open thoracotomies, I've been on a couple of. I've been up to the helipad for a couple of those as an ED.
Yeah, don't worry. I'll introduce you to Rob Scott, who I'm sure will be your next interview.
Great.
Yeah. He'd be a great person to
talk to.
And
so, have you been with St George ever since?
No, so I went back to the UK.
Oh.
I was a consultant over there for 3 years, had another child.
Did you become a consultant in Australia, then go over, or you finished off your training back in the UK? So, okay.
And then, was a consultant in the UK for 3 years, had another child, so we have 3 kids, and then decided to make the jump back over here about 6 years ago.
So I'm interested to know what it's like having kids as a anaesthetics boss, like how you manage work life in that regard, but also how you make a decision between UK and Australia with a family and a medical career. So, like, how was being a father and a registrar or a consultant?
Yeah, like it's busy, but I think when you have kids and you have a career, it's always busy. Yeah. I think actually it's harder for my wife than for me. She's a GP, and although I am a hands-on dad, there's some stuff that the kids want, and there's sometimes that they just want mum. And invariably, the tension is between forcing them to have me look after them versus
That's all you get, guys.
So it's a balance. Yeah. And what you try and do is see plenty of your kids and do a good job at work and hope that meets the balance that you want.
Yeah. And so how do you decide whether to live in England or Australia personally for you?
I forgot to say that I did actually work in Perth when I was an intern, so post-intern job. I came out to Perth as an SRMO. And then, so that was my first hit of Australia. And that's why we wanted to come back. It was one of the reasons that we wanted to come back as a fellow. So I'd always wanted to live in Australia. I always wanted to live somewhere that other people went on holiday.
Yes. And that's what Australia has definitely become, isn't it? Yeah. We get a lot of UK doctors coming over and a lot of questions about the differences in working as a doctor in UK versus Australia? I guess you could speak from the anaesthetics point of view. Have you found there's some pretty like obvious differences between the two systems, or is it pretty similar?
No, it's pretty similar.
Oh, nice.
The machines are the same, the drugs are the same, the anaesthetic nurses are the same.
Yeah.
They're all amazing.
Same medicine, better weather.
Better weather. There are some nuances to it, so maybe they're Sydney based as well, but for example, there's much less elective work in public hospitals here. It's all done in the private sector.
Right.
So there's more choice over here from that side of things. The downside is that as a public anaesthetist, most of our work is emergency work. Now, I quite like that. I find that enjoyable and interesting. But if you're trained to do some elective work, then mostly that will be found privately.
Right.
It's a balance, like everything. The NHS, the system in the UK is pretty much 90% NHS work, so there isn't much in the way of private medicine. And again, there are good and bad sides of that. But over here, I think it's probably maybe 60-40.
We talked a bit about your career, but I'm interested in knowing the key decision point for you when you decided to become an anaesthetist. Like, why an anaesthetist? Why not anything else?
Yeah, I guess I had enjoyed everything pretty much in medicine. So all the terms I did as a medical student, I didn't want to be a cardiothoracic surgeon. I kind of had made the decisions about some of those heavyweight sort of specialties, but I didn't really know what I wanted to do. And I hadn't ruled out GP. Often in med school, I think general practice is given a terrible kind of rep, but
it's always what specialty do you want to do?
Yeah,
and
people don't
people fall back on.
It's a sort of a failure specialty, but the perception is 60% or more of medical students will become general practitioners. And actually, if I had my time again, don't tell anyone. If I had my time again, I'd have been a GP.
Wow.
Because you get set up quickly. You're in control of your own destiny. The stuff that interests me as much as the medicine does is all the non-clinical part of this job, which there's ample scope to do in general practice.
Example?
So education is a good example, but managing people, managing processes, quality improvement projects, quality improvement work, leadership and management, all those non-clinical parts of becoming a senior clinician, there's ample scope for those. And you're in control of your own destiny, right? You can choose the hours you work and the places you go. And as a dad of 3, the non-medical time becomes as or more important than the time you spend at work. And all the mates that are now general practitioners are all very happy with their lives and pleased that they either fell into it, were pushed into it, or chose to do general practice. However, I did ED in Perth and loved it. And I think if I'd have stayed in Perth, and 5 of my mates stayed after we all left, and most of them became ED physicians, I think if I'd stayed, I would have done emergency medicine. It was great over in Perth. But I came back to an intensive care job, just a standalone, I guess, SRMO equivalent job. And the people that covered the on-calls overnight were anaesthetic registrars. And they were all...
On-call for what? Just
for the unit. So the senior cover.
Right, for an ICU. Okay.
Yeah, it was uncoupled at that point. So there wasn't an intensive care specialty.
Specialist.
No.
Yeah, okay.
So mostly it was anaesthetists who subspecialised in intensive care, who then ran the units as consultants. Okay. And any which way of doctor could staff the middle kind of tier. But they were mostly the senior support in the hospital after hours were anaesthetic registrars. And they were all, nice people who loved their job and were happy and were good doctors. And I was like, I want to be like that.
Yes.
And so I decided to try my hand at getting an anaesthetic rotation and fell into one.
And it's one thing to see and admire doctors and kind of want to emulate them and go on their path. But then when you start the job, it can be a bit different. Did you start anaesthetics and just be like, this is what I want to do, even when you were junior? Or was it something that over time you liked more and more, and it was confirmed that that's what you wanted to do? Like, was it an instant kind of hit, or was it something that needed some time?
I definitely felt instantly comfortable in the decision that I'd made, but uncomfortable in knowing nothing about the specialty that I'd chosen.
Yeah.
It's, again, different to here where as an SRMO you'll get exposed to the critical care specialties.
But it's a very, like, at least at St. George, it's a very competitive SRMO year,
Yeah,
isn't it?
yeah.
Hopefully I think there's some other, like, other hospitals are also doing critical care
Yeah, I don't
SRMO.
know much about the junior system over here, but
Right.
certainly in the UK, you go from having never been in theatre to being an anaesthetic registrar day one, having no experience. So you go back to feeling like a medical student where you don't know very much about the processes or the way that people do stuff and the medicine behind it. The learning curve with anaesthetics is pretty steep in a good way. So you get pretty proficient at giving a standard anaesthetic to a simple for a simple procedure to an uncomplicated patient pretty quickly. You don't actually have to know very much to do that. It's all practical. But what you realise when you take the exams is that there are some good reasons why you do things and some bad reasons and things you shouldn't do. And so you backfill the experience stuff with some knowledge, and your world just opens up to the eclectic mix of recipes and drugs that you can use to help or hinder patients along their journey.
And all the kind of, like you're saying, you get really proficient at the standardized safe patient, no comorbidities, normal use case. But then all the exceptional use cases is where the bosses come in. I guess I'm interested for you why you didn't choose ED or ICU, because I'm interested in critical care, and I don't know which way really. I've only done an ED term. I didn't get ICU this year, so I'm going to try and do some ICU and anaesthetics later on. Luckily, I got a peds term though, so that's good. But yeah, how did you make the decision for yourself personally, and what advice do you have to other junior doctors like me who want to kind of make a decision between the three? And is it just trial and error? Do you just have to try it all and see what clicks?
It seems like it's a dirty word or dirty process these days. You're not allowed to meander around different specialties and try on a few different coats and see if they fit. And I think that's a real shame. They made a decision in the UK, they being the sort of, the powers that that drive policy or structures around recruitment and subspecialization, that if you had done orthopedic surgery as a junior doctor for 5 years and then ended up being a general practitioner, you had wasted your time. That was the decision that was made. And it would have been much smarter for that person to have been funneled into general practice earlier. The downside of that is that all that knowledge based around trauma and soft tissue and hard tissue damage that they take to general practice, where you need different people who can
Different niches, right?
have different niches into skin and bone and a women's health or whatever it might be. I don't see that as a waste of their time. I just see that as improving their skill set in a niche part of what we all need to be able to do as a collective, for example, in a general practice. So, me wandering around doing a bit of ED, and I did about a third ICU during my anaesthetic training. So again, back in the UK in the sort of early 2000s, you do a lot of intensive care, and I loved it. And again, thought heavily about being an intensivist. The downside, and a thing I keep coming back to as I sort of talk to people about their career decisions, is you'll love everything you do as a junior doctor because it's all the fun stuff. You've got to work out whether the job that you will be trained to do is the job you want. So look at a consultant intensivist or a consultant anaesthetist or indeed a consultant ED physician and say, that's the kind of job that I want at the end, because they're not the same as the job that you do as a junior doctor in those specialties.
And you have to be comfortable with the boring or the unsexy side of the specialty.
Right.
Like ED bosses, they get the good stuff, but they get a lot of the bed block, logistics, staffing. I mean, it's an ED consultant that does the roster.
Yeah.
That's mind-boggling to me, because that's hours of work that like it's thousands of dollars a fortnight that like of healthcare expenditure that could be better spent.
So that's the other part to the decision making, I think, is that look at the specialty you think you want to do. Look at the worst thing about that job. If you can put up with that worst thing, that specialty is for you.
So what's the
Because
worst
the fun
thing?
stuff is the fun stuff.
Yeah, yeah. Everyone loves the fun stuff. But what's the worst thing about being an anaesthetist?
So I guess it's that, sitting in a theatre, watching a machine, bing-bonging at you while you have your colleagues ferreting around in an abdomen for 5 hours. If you can put up with that, because the fun stuff of getting that patient safely asleep and getting them safely emerged and dealing with their pain relief, those portions of the anaesthetic which are small, they're the fun stuff.
Yeah.
And it's the same for, I don't know, radiology. Feeding little wires into people's brains and putting coils up there is fun. Sounds fun.
It's crazy, yeah.
And a bit crazy. But sitting in front of a computer screen and reporting on
100 chest x-rays.
CTs or chest x-rays in a dark room for 90% of your day, if you can put up with that, you should be a radiologist.
So Lawrence, I'd be interested to know what scares you in your job, because I think doctors are always seen as these brave citizens of the world working for New South Wales Health. But there are some scary moments in every kind of physician and clinical job. So personally for you, do you ever get scared, or have you just got like that kind of protocolized ability to assess any kind of chaos?
No, I think if you don't feel a bit of emotion probably every day, then you probably should stop being a doctor.
Right.
I think it's an emotional profession, and human beings feed off other people's emotions. You see that in kids, and mostly patients have some emotions floating around when you see them. So I think if you don't have lots of different emotions during a day, maybe you should take a holiday or think about another career. Medicine is scary because it's all the grey, right? It's not black and white, mostly. There's some easier bits to the day and there are some harder bits. But I was just talking to a colleague earlier who is going up to theatre to anaesthetise a 90-year-old patient for a carotid stent. I mean, that's going to fill anyone with anxiety, even if you're the person who helps anaesthetise people for carotid stents every day. Yeah. So I think there's always apprehension, especially if there is uncertainty, and I think medicine is full of uncertainty. I think that's why often people find it a hard specialty, is if they're not comfortable dealing with a bit of uncertainty. And you've got to compartmentalize it to some degree, and sometimes you have to make decisions where you've got to remove some of the emotion from those processes, and that's where cognitive aids and training and protocols can help. But if you forget that there is a patient, another human being at the centre of all this, then you as I say, you're probably in the wrong job.
When was the last time you felt that kind of fear? Like, have you had any?
Probably yesterday.
Recent,
I'm just trying to think. Yesterday I was running the floor, so I was the duty anaesthetist, and
what does that mean? Does that mean you're in charge of all the theatres as a kind of central
outside work and the staffing of inside? So you make sure things are running smoothly. Right. And more our job as anaesthetists is sort of being pushed out of theatre and pulled into the other critical care area arenas. Lots of anaesthetics now get given in satellite areas like MRI and CT and cath lab. But we also go down to ED and help with some of the sick patients who either need support down there or indeed need to come to theatre. And there were a couple of those patients yesterday. One of the nice things that has come out of COVID, I think, if there can be nice things, is that different silos of subspecialty have come together and are more used to interacting with each other. So my relationships with my colleagues in ED are much stronger because of the need to address the pandemic. Same with intensive care. So I think our jobs in general are made easier by having lines of communication and relationships with people in those other areas. And so my job was made very much more easy yesterday because I knew lots of people down there.
You know who to talk to, yeah.
Yeah.
Before you were talking about how if you don't feel emotion, you're probably burnt out. Have you ever suffered from burnout in your career, or had colleagues or close friends who've been burnt out? And how did you kind of resolve that, if it was resolved?
Yeah, like a little bit of both, right? You definitely see colleagues and there's some support. I think burnout is a sort of the extreme that people often talk about extremes of whether it be health or mental health or physical health, but actually it's all a continuum, right? So some days you feel more stressed than others, and some days you feel more saturated. And I think it's about managing that. It's the sort of small things on sort of daily or weekly basis. I definitely felt under the pump at the end of my anaesthetic training, which is one of the reasons we came over to Sydney for a fellowship abroad, is to have a bit of downtime with 2 kids. I was commuting sort of an hour each way with young kids. But then when we went back to the UK to finish off, and I was a consultant, before we came to Australia, the forever move, I was commuting 2.5 hours each way for 3 years.
You did you did 5 hours of travel a day for 3 years?
Yeah, 4 days a week.
Wow.
Yeah.
You must love that job.
And it was a great job, and I had a great family life. And so the balance was that I had something terrible that I had to kind of do it every day, but I had some good out of it, and that's the balance. I didn't want to do it forever.
For anyone else who has to do that kind of travel, now there is a podcast which you can listen to for that long drive.
But it's if it's something where you can see the end in sight, and there's other things that keep you afloat, whether that's your friends or your family or your hobbies, and I'm a big believer in hobbies. I take my fads very seriously.
What's a fad, sorry?
Oh, the things that you kind of do.
Fads. I'm all about. I used to skateboard and taekwondo, all sorts of things. So tell us, what do you do when you're not working? What are your fads?
In between.
Beer tasting was one.
Well, beer making.
Oh.
So I make bread, bake bread and brew beer. They're currently the 2 passions.
So what? Okay, because making bread is hard. I bought a thing off Kogan and tried it for a month.
Right.
Yeah. But do you make a good sourdough? Is that what you?
Yeah. So currently make plenty of sourdough, probably 6 loaves a week.
Wow.
To feed the kids, and the kids are always just hankering after tasteless, square, white bread.
And that's what they want. And you 3 hours of eating a thing, and they don't want a piece. They want the Wonder White.
Not the 36-hour sourdough that I've lovingly prepared for them.
Give us Wonder White.
And again, it's like anything. It's about the journey. I like the process. I like getting better at something. And so bread I've been doing now for 13 years, and I'm pretty happy with the product, but it's different every time, and it takes some time. You have to invest some energy in it, and it's always, I'm hopefully always improving. It's the same in medicine.
Wow.
Actually, in anything in life, I think, if you want to commit to something, you'll have seen it with your videos.
Yeah, exactly. This has been a really fun fad to kind of get slowly better and better, and use better equipment and learn about all that equipment to kind of deliver messages more efficiently and beautifully. I want it to be a very aesthetic thing as well.
And another.
By the way, new lens. This is a new lens. So I'm looking
on me.
Yeah.
Oh,
no,
it probably should be on you. So. And I think we as human beings, not only do we want to keep improving, but also connections. And one of the things I think you do is try to connect with people, whether it be one-on-one with the people you're interviewing, but also with the audience, the medical students that are listening in. Yeah. And I think baking bread is a great way to connect with people.
It is.
I bring it to work. Yeah. It's one of the base elements of
every meal.
Every
So
meal.
I'm French, right? That's my background.
Well, look.
Without good bread, what would France be?
Yeah. and baguettes. You know, that classically.
Have you tried baguettes? Making baguettes?
Yeah.
Harder, easier than sourdough? Different entirely?
A different technique.
Right.
The golden age of French baking happened when there was a symbiosis of sourdough starters and commercial yeast. When the two were married together, it made amazing French bread. And that's
what
why.
years are this? Is this like
maybe sort of turn of the last century?
Oh, okay, 1900s.
Something like that. So essentially, people used to bake with sourdough. It takes a long time, but produces a great product. Sometimes a bit heavier than you'd like, but you forgo that for the flavour. Commercial yeast comes along and you get massive instant rise, so quick turnaround, very airy bread, but doesn't taste very good. And in France, there was this big kind of,
cultural clash?
Yeah.
Yeah, right. I'm not surprised.
Yeah.
We don't want the new thing.
No.
That's a terrible accent, sorry.
But when people started to use both together, they made amazing bread.
Kicked off. Yeah, right.
And that's what when the golden age of French baking was at its sort of peak.
Wow. Thank you for sharing that.
Yeah.
I love asking this question. It's only something I've thought about recently, and it's what would you do if you made $10 million? And I feel like it gives you an insight into whether people like their job, basically. So what would you do if you like if you really put yourself in the position, like if I gave you $1 million, $10 million, $1 million doesn't get you anything.
No, not anymore.
I used to ask that question, but everyone was like, I'd keep working because I have to.
Yeah.
But what would you honestly do if you made $10 million and you could retire?
The 10 million is an interesting number because I think I've spent some time thinking about this with friends, mostly
really?
over beer.
Yeah.
10 million is the point at which the money that you earned from the interest is enough to live on.
Absolutely. It's 200 grand a year if you have the right ETF or whatever,
So you could never touch the 10 million and it would turn over your enough income to live.
Yeah.
So that's an interesting one that it's just on that borderline. I still need to fill my time.
Yeah, exactly.
Do you know, if someone...
There's only so much bread you can bake.
Well, you say that, but it's 90 loaves. 90 loaves is the point at which you need to break even in a bakery.
Oh.
So if you can bake over 90 loaves a day, you'll break even in a bakery.
That's a lot of loaves.
A small bakery.
Yeah.
So I think if anaesthetics didn't exist, I'd open Boss Bread and Beer.
That's a brilliant idea.
But because anaesthetics does exist, I would still do some anaesthetics because I love it. I would just pick the list that I did.
You'd have a customer, that's for sure. I'd probably go for 10 of those 90 per day.
But yeah, I think I would love to own a bakery. The downside is that you end up, I think when you move a passion hobby to something that has monetary kind of value to you or to other people,
or that you're dependent on,
it becomes a job, right?
Exactly. That's why I like the idea of multiple hobbies. Like I don't depend on YouTube to survive.
Yes.
And I guess I do depend on medicine to survive, but thank goodness I absolutely love it.
Yeah.
It's a wonderful career. Yeah.
And
bread and beer. That's fantastic. That's really catchy.
But you'd probably end up not.
I will share it when it opens.
Not baking the bread though. You'd end up employing someone to bake the bread.
But maybe that'll be nice if you train them. It's like intubating. How often do you intubate? Now you got the youngsters.
Less time.
You got us poking around.
Although sometimes I will load if I'm working with a senior fellow, if we're doing a complex case upstairs, and I will load the question to make them offer me the central line.
Oh, what do you mean?
So I don't get to do any of these fun things anymore.
Oh, yeah.
And so I'll often say, "Oh, when was the last time you did you put a central line in?" And they say, "Oh, last week." "Oh, I haven't done one for 3 months."
Is that all right if I just...
And then they'll say, "Oh, you should do it today." I'm like, "You sure?"
Sure.
And then they'll let me. So yeah, I do sneak the odd procedure in when I can, and it's good to keep your hand in.
Absolutely, because is it like riding a bike, or like if you a central line, by the way, for medical students listening in, is when you want to get access that's much better than a cannula in the forearm. It's a big vein, usually the internal jugular, sometimes other ones, but usually the internal jugular. You need an ultrasound, you get a guide wire in, you put in a bloody big tube in, and that gives you heaps of access for big fluids or really quick administration of drugs to the heart and the rest of the body. So sometimes, yeah, as you're saying, you try and get your hand in to do it. And I've totally forgotten what I asked.
The balance between you doing it or training other people to do it.
Yeah.
So
Oh no! If it's like riding a bicycle, now you've probably done a lot of central lines in your time. But if you haven't done it for 3 months, for example, can you just do it naturally, or do you try and just review some how to get the protocol and process in order?
I think that any skill that you don't do very commonly, there is decrement right there. You will lose some of those just small motor kind of nuances to the process, and I think you definitely want to keep those skill sets up. There are different ways of doing that, and one of them is just to do the procedure, but watching people do procedures teaches you quite a lot about...
As an active observer,
Yeah.
which is a big thing I tell medical students, because there's two forms of
Agreed.
being present in a ward round. There's the active and the passive. And the way that you can make yourself be an active observer is you have to prepare 3 questions while you're observing. And if you're looking at something being done with the expectation that you will have to ask 3 questions. So I always ask medical students, you have to ask me a question at the end of whatever we do in your exam. And so you're looking with the frame of mind that you have to ask a question. So you have to find out what you don't understand about what's happening in front of you. And that kind of switches you on.
Yeah, nice.
Fantastic. Well, I think there was one last question and then... Oh, here we are. Question 10. This is a good one. What is your favorite anesthetic drug and why? And the other way to ask this question, which someone else told me today to ask, is what anesthetic drug would you be and why?
Oh, right.
So you can pick however you want to answer that. You're not rocuronium. I'm not not bored to...
Look, it would be hard for anaesthetists not to choose propofol.
Wow, yeah, okay.
Because it's probably the number 1 drug that we would give for a general anaesthetic. It's a hypnotic that is milky white. That, as I say, I reckon probably 99% of general anaesthesia is induced in that way. And
99?
I reckon.
Wow.
General anaesthetics, probably. We don't give it to the very sick or use it judiciously. And some patients don't get an intravenous induction. They maybe get a gas induction. So pediatric patients of a certain age may well just breathe the gases down without propofol. Although I can bet you most of pediatric anaesthetists would end up giving propofol at some point during their case. And it was brought out around the same time as laryngeal mask airways. So it was a marriage made in heaven. Right. Because propofol is great at relaxing your laryngeal muscles, and LMA sit in that area. And so when the two came out together, if they hadn't come out at the same time, we would probably still be using tubes and thiopentone. But because they came out about the same time and they were perfectly matched, we ended up with propofol as our sort of number 1 drug. And I think it's still probably quite hard to beat. I don't think anyone's really surpassed it in terms of hypnotic. Yeah. There are some fancy drugs out there that people are now sort of starting to use for sedation.
Ketamine's in vogue.
Ketamine is very in vogue in ED.
But it's not a general anaesthetic.
It is. It is a hypnotic.
Oh, right.
Yeah, so out in the HEMS world, they would use it as the hypnotic agent.
Yeah.
But, you know, there's the other part of me thinks that something like remifentanil would be a good drug to be. You know, a drug that you can give that keeps patients awake, but they forget to breathe. Now, that's a cool drug.
That's very strange, isn't it?
And I just remind you, I'd be like, take a deep breath for me, and they would take a deep breath, wake up and take a deep breath.
Yeah.
That's a cool drug.
Yeah. We'll have to look into the mechanisms of action of remifentanil later. I've forgotten that one. Laurence, thank you so much for spending the hour with me and with everyone. It's been really, really enjoyable, and I really appreciate it.
Pleasure. Am I supposed to ask you a question?
No.
I thought you said 3 questions.
Oh, sure.
I'm supposed to hold 3 questions if I'm going to be actively part of this process.
Yeah, well...
I asked you one at the beginning.
Yes.
I'd love to hear your thoughts on that.
So the question you asked me at the start was, what have I learned doing these podcasts, talking to senior clinicians? And I do try to I tend to go towards personal questions because that's what I'm more interested in, because it's what I'm interested in, and it's also what's not exposed to medical students.
Yeah.
Like, it's very hard for a medical student to spend this amount of time with a
Yeah.
consultant, and hence why this is valuable.
And human beings learn or gain insight from stories, right?
Yeah.
Stories are
Emotional stories.
how we've
And that's,
always delivered information to other people. And you
Yeah.
hear that corridor chat. Did you hear about this case that I had? Da 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 da. And often it's twinned with emotion. I find that with the learning conversations. You start with emotional questions because it's how people are feeling that is important in how they're going to
yeah. And
move
so if I'm
forward.
teaching medical students, I always say, this is how a patient dies. I go right to like, this is how they die, and then I work backwards from that. So how do we stop that? Da, da, da. And that, so they're already eyes open, and then go back. What have I learned? I think I've learned not to rush too much. I've spoken to a couple of, I've spoken to a couple of big bosses who, when they say if they had their time again, they might have not, and sometimes it's off the record, but they might not have like gone so gung-ho so early in life on that specialty so quickly. And which is, it's interesting because I'm keen to get into a training program and get cracking, but I think it's a good reminder that the way that medicine's going, we're going to live till 90, 100, pretty standardized, and we'll probably have a good health span, so we'll be working much later. I expect I'll be working into my 80s. By 2070 or whatever it is, I'll still be working fit. So what's the rush, right? Like, don't sacrifice having a balanced view. So I would like to do a lot. I want to try locuming. I want to try doing all sorts of things. But yeah, that's kind of the key thing. Like, what's the rush? And that's made me think a bit more as to, like, being a well-rounded doctor is really important. And my kind of goal in medicine, like, if people ask me, why do I want to get into critical care? My goal is so that if a patient dies under my care, I can say they had the best chance of survival. I want to be able to say that and feel it emotionally. And right now, I totally can't say that. I can say I got the right person. That's my job right now as a junior, is getting the right person to see the patient and keeping them alive long enough to get the right person in the room. So yeah, that's kind of my goal, and that's what I've learned from these interviews.
I think people underestimate how much of a skill set they have. There are some overconfident doctors out there, but I think actually I felt along the way mostly I was trained well. Mostly medical school did prepare me. Mostly my anaesthetic training did prepare me so that I had enough of a skill set to transition to the next point. I feel like medicine, probably in this country and indeed in the UK, has worked it out enough that you get trained well enough to do the job that you either want to do or are intended to do.
It's incredible they can do it. Like, just medical education as a thing is so difficult to standardize it. And I agree. I feel like equipped enough to do the job that I'm in. Yeah, I also spend a lot of time on podcasts. There's some good anaesthetic ones.
Yes. Actually, a lot of the registrars will swear by
Yeah.
some pretty good ones.
Great. Well, thank you so much again, Laurence. I'll see you all in the next episode. Thank you so much for staying tuned till now. If you haven't yet, please consider leaving the video a like. That's how YouTube takes it up and shares it with the world. And if you enjoy this kind of content, you can also consider subscribing. All right. Have a good day, and I'll see you in the next video.